Hi, my name is Alicia Morgans, and I'm a GU medical oncologist and associate professor at Northwestern University. I'm so excited to be here today with the PCF team to talk to Dr. Tanya Dorff. Tanya, can you introduce yourself?
Hi, I'm Tanya Dorff. I'm a medical oncologist and associate professor at City of Hope near Los Angeles, California, specializing in GU and interested mostly in prostate and immunotherapy.
Wonderful. So the PCF team asked us to talk a little bit about COVID-19 and how it's affecting us and our practices, really so that patients and their loved ones can learn a little bit more about what they need to think about with COVID-19, given that it's hit the world with such force. I am so excited to talk with you because you have been breaking ground with some wonderfully important immunotherapy treatments in clinical trials, including CAR-T and many other things. And I just wanted to get an understanding from your perspective, how is this affecting the research that you're doing and the patients that you're caring for day to day?
It's been really a struggle. There's general guidance that a phase 1 first-in-human trial may not be the right thing for patients right now, especially trials like CAR-T or bispecific T-cell antibodies, where they're in the hospital so much. On the other hand, these are therapies that are already showing some therapeutic promise. So I've been talking with some of my colleagues in the other disease specialties and trying to make common sense decisions. But right now we're blessed, our hospital is not having COVID patients and we have enough availability, but that's, aside from the more ethical and prioritization sort of perspective, the other perspective is making sure our hospital has enough resources if we do start to have a lot of COVID cases and we need those beds. We don't want to have patients in getting immunotherapy on a phase 1 trial when someone needs immediate life-saving from COVID.
It makes a lot of sense. I'm sure that patients are thinking about this. What about patients who are already on these trials? Because these do require that patients are admitted to the hospital for their treatments. Are they continuing on, and how are you keeping them safe while they do that?
So we've maintained really strict checkpoints of entry. So anyone entering the cancer center is screened with a temperature check and asked a series of questions. We also implemented a no visitor policy, which is really hard for our cancer patients. It means that some of our patients who are in for weeks or months even can't have visitors. Fortunately, we have technology like Zoom, like you and I are chatting today, and that helps a bit. But patients who are on trial are continuing on trial. We're making some modifications. When a patient, for instance, is supposed to drive in just for a checkup visit with labs, a lot of sponsors have allowed some flexibility to say, the risk is greater than the potential benefit when it's maybe every study visit is important, I'm sure, but maybe this is one of the less important study visits or time points. So that's how we're mitigating the risks best we can.
Well, I really do wish you continued luck, and I'm glad that you are faring so well and that you are able to take care of those patients who are still on the trial, especially since, like you said, there's a lot of excitement and enthusiasm, and City of Hope is really a very specialized environment and a special place where this work is being done, one of the few places in the world. So, so I do wish you luck as you continue. But for those patients who are just out in the real world, those patients not on clinical trial, what is your guidance for them in terms of COVID-19? Are they at increased risk? And maybe are there certain stages of prostate cancer where they would be at higher risk than other stages? What are your thoughts on that?
So that's a common question I get from my patients, and I'm sure you do as well. So the nice thing is that hormone therapy, things like the Lupron type injections we give, or the androgen blocking pills like enzalutamide or abiraterone, that those don't increase a patient's risk. They are not immune compromising. And I think patients get a lot of reassurance out of hearing that. The bigger issue is, reducing number of visits to the clinic. So we're doing telemedicine for someone on abiraterone, for instance, where you need to check the labs every month for the first few months to look at electrolytes and liver tests. We can do that using a local lab and then a telephone visit or a video visit. We're also maybe using more of the 3-month or 4-month injections of LHRH therapy instead of the monthly to try to keep people from needing to come back to the cancer center. So we're making those types of choices, but really on a case-by-case basis, we call the patients and talk to them, or when they come in for their injection, we talk to them about, switching to a different length of treatment of their injection. For physicians, I don't know if you saw, NCCN issued some guidance trying to say which treatments maybe could be delayed or postponed safely so that oncologists out there who have questions about it could at least hear from the collective wisdom of some prostate cancer doctors around the country.
Absolutely. And I think, at least in our practice, we're trying to, when we have a choice, limit chemotherapy use. I assume you're probably doing some of the same.
So NCCN and I, don't feel that chemotherapy should be completely excluded. I mean, there are patients who are symptomatic. They're facing a much greater risk of death from their prostate cancer, perhaps, than they are from COVID. And we don't yet truly know that chemotherapy patients are getting COVID at a greater rate or having more severe effects of it. I mean, it makes sense that that might be the case. And obviously, we want to avoid immune compromise. But we haven't said no to all chemotherapy. We have delayed it or stretched out intervals. And certainly if we have another option, we're going to choose the non-chemo option. But there are patients who may still really need it, and so they should probably still receive it.
I completely agree. We actually are starting someone in my clinic in the next day or so. We started a few patients last week. There are absolutely situations where men with prostate cancer are facing bigger challenges from the cancer we know than from the chemo and the possible infection that could affect them. So we are absolutely using chemotherapy in those settings. And when you are doing that, what are the recommendations that you have for patients? What do you tell them in terms of keeping themselves safe?
Well, so the self-quarantining or isolation, avoiding going out to the market where you might come into contact with more people who have COVID and it's more of an unscreened environment. I think that's the most important thing. But then the general things that keep people healthy and maybe help keep the immune system strong are getting good sleep and maintaining good nutrition and exercise. These things keep our bodies strong, which we need. If we unfortunately were to get infected, we need to have those reserves.
I agree. Always washing hands, having that extra hand hygiene or extra consciousness about it is also really important too, I think.
Absolutely. That's the number one thing, hand hygiene.
Absolutely. So as you're thinking about patients who have had things like radiation or just on hormonal therapy, I think it's encouraging, and something that we're sharing too, that we don't think they're necessarily at higher risk of having an infection or a complication. And we actually in our clinic have had several patients with prostate cancer who have been on hormonal therapies who have been infected, or so we believe. There are at least a few in my clinical practice, and they've all actually thankfully recovered very well and don't have any sequela of that. But there are actually questions some patients have about immunotherapies, checkpoint inhibitors, which are not widely used in prostate cancer, but are used for some patients. What are your thoughts for those? Because that is a little bit of a different situation.
Yeah, it's hard to know. It shouldn't impact a patient's risk from COVID, the checkpoint inhibitors, generally speaking. Because they're not suppressing the immune system, and I don't necessarily think they divert the immune system enough either that you wouldn't be able to mount a response to COVID. But again, we're taking a step back and thinking, when can doses be delayed? When can someone maybe take a brief hiatus if their cancer is in good control with a therapy like that? Because even though the therapy itself may not present risk, there's just that risk of leaving the house and coming into the cancer center. One thing we grappled with also was with a therapy like Provenge. What are your thoughts on sipuleucel T during this time?
We actually are starting somebody in the next couple of weeks on that as well. I think that my concern with that is actually engaging with the healthcare system and really having so many visits, but we have counseled the patient that we're starting really about hand hygiene. He self-isolates often anyway, that's just part of his normal life, but will continue to do so. I don't feel like we have enough information to tell us that that's too dangerous yet, but I definitely have asked him to be careful.
It's interesting that although I was concerned leukapheresis might be a high-risk procedure, it's actually not considered to be as high risk as things like bronchoscopy or biopsy. So whereas we screen patients for COVID prior to CAR T-cell therapy, we don't screen them before the leukapheresis itself. They're getting checked before lymphodepletion chemo or before the infusion of the T-cells.
It's, I think, something that is really, in terms of our knowledge, it's really evolving. And we're participating in some registries trying to enter information about our patients with cancer, including prostate cancer patients, just to round out our understanding, because at this point we have some information from China, but I feel like it's first of all, it's on very few patients, and most of them, if not all of them, are not going to be prostate cancer patients. So still a lot for us to learn. I'm sure you're participating in similar research efforts to try to help physicians and patients understand more about this disease.
Absolutely. And one of the big questions we've been grappling with is the tocilizumab, which is the anti-IL-6, which calms down some of the inflammation created by the virus. But we use it in T-cell therapy, but there the T-cells are the source of the IL-6, and it's sort of a different dynamic. So we try to stay in touch with the Italian data. You know, they accrued 300 patients in 24 hours. And so we'll have more firm data, although not probably randomized data, to guide our decision making there. But those types of questions really allow us to look to our colleagues from across the oncology spectrum and experts in immunology and even infectious disease to come together, put our heads together and try to understand what we're seeing in the data, what's most promising, what we should have available for our patients.
It's all going to be learning, and I'm glad that you're doing that. I'm glad that you're trying to push the boundaries so that we can answer these questions. So as you think about who you would like to interview, who you'd like to talk to next about COVID-19 and the implications in terms of prostate cancer and your practice, who do you think you'd like to speak with?
Well, I have tremendous respect for Chuck Drake as an immunologist and oncologist. So I'd be super interested to hear his perspective on the intersection between cancer therapy and COVID.
I think that would be fascinating, and I really, really look forward to hearing that discussion, and I really do appreciate your time today. Thank you so much, Dr. Dorff.
Thanks, Alicia. Thanks, Dr. Morgans.